This explainer is based on Visually Induced Dizziness, VID, a Vestibular Physician's Deep Review of Pathophysiology, Assessment, and Rehabilitation, published by Australian Dizziness Clinics.
Welcome to this explainer. If you're a vestibular physician, a neuro-otologist, an advanced ENT trainee, or a specialist physio, you are in exactly the right place. Today, we're unmasking a phenotype in the dizzy clinic that's incredibly common, highly treatable, and yet it gets overlooked all the time. We're talking about Visually Induced Dizziness, or VID. Let's set the stage and look at how this actually shows up in your practice.
Okay, picture this. Your patient is severely destabilized just by walking down a supermarket aisle, or scrolling rapidly on their phone, or even just standing near heavy moving traffic. But when you put them through your standard vestibular function test battery, the VHIT, the calorics, the VEMPs, everything comes back completely normal. It's frustrating, right, for both of you? But a normal test battery here isn't something to just dismiss, and it certainly doesn't mean the dizziness is purely psychogenic. Actually, it's the exact signature of what we're talking about today.
So, let's jump into Section 1, defining the syndrome.
What exactly are we dealing with when a patient presents this way? Well, the literature defines visually induced dizziness as a clinical syndrome where exposure to complex, moving, or optic flow-rich visual environments triggers dizziness, unsteadiness, or spatial disorientation. And crucially, we can't blame this on primary oculomotor dysfunction. The main takeaway here? VID is triggered by ordinary, everyday, busy environments that a healthy person wouldn't even notice. But for these patients, a crowded shopping mall or watching an action movie literally becomes a profoundly destabilizing experience.
The core deficit at play here is really fascinating. It's an overwhelming, disproportionate dependence on visual input for spatial orientation. Under normal conditions, our central nervous system dynamically weighs visual, vestibular, and somatosensory inputs, right? It adapts based on the context. But in a VID patient, there's a pathological visual upweighting. They become overly dependent on their vision just to figure out where they are in space. So when that visual field gets chaotic or complex, their balance system essentially just crashes.
Section 2. Untangling the terminology. Let's trace the evolution of this condition and clear up the alphabet soup of diagnoses out there.
It's really interesting to see how the naming of this condition has shifted over the last 4 decades, which completely mirrors our understanding of the mechanism has evolved. Back in 1995, Braunstein coined the term visual vertigo to describe this response in patients with known vestibular disorders. Fast forward to 2013, Braunstein and Golding broadened it with space and motion discomfort, catching patients without any obvious peripheral pathology. And then in 2017, the Barney Society brought in visuospatial sensitivity as criterion C of persistent postural perceptual dizziness, or PPPD.
Now, the current consensus can honestly be a bit tricky to navigate. The Barney Society recognizes visuospatial sensitivity as criterion C of PPPD, but they don't actually define VID as a standalone diagnosis. However, to bring some real clarity to your day-to-day practice, visually induced dizziness, VID, is the preferred modern working label. It's just the most practical term because it covers both that isolated visuospatial hypersensitivity and the visual-triggered phenotype within the broader PPPD spectrum.
Moving on to Section 3, sizing up the scale, epidemiology. Let's look at the actual numbers. This stark contrast is a real wake-up call. When we look at community data, like Murden and Childers' systematic review, we see self-reported visually provoked dizziness in about 15 to 20% of adults who screen positive for chronic dizziness. But when Cousins and colleagues actually quantified visual dependency in consecutive patients at a specialist neuro-otology clinic, a massive 57% met the criteria for clinically significant visual dependency. That is a dramatic jump when you step into a specialized setting.
Let that sink in for a second. You are undoubtedly seeing this every single day in your practice. With well over half of specialist neurology patients presenting with significant visual dependency, this is literally sitting in your waiting room right now. It might be their primary diagnosis, or it might just be masking as a stubborn complication of something else.
Section 4. The patient profile. Risk factors. So, who exactly is the typical VIP patient?
The literature is remarkably consistent on this specific cluster of risk factors. Female sex is a strong predisposing factor. We also see a major link to underlying anxiety or panic disorders, which is driven by an amplified limbic response to vestibular symptoms. Migraine biology is another big one. It independently elevates the risk because of a pre-existing central motion processing amplification. And, very often, we see a prior episode of an acute peripheral vestibular event, like neuritis or labyrinthitis. Chronologically, this whole cluster usually strikes patients right in their 3rd to 5th decade of life.
Next up, Section 5, Clinical Typology, Primary versus Secondary Presentation.
VID generally falls into 2 distinct categories in the clinic. First, you have primary VID, meaning it arises completely de novo without any preceding vestibular event whatsoever. Then, much more commonly, you have secondary VID. This develops as a complication after a peripheral vestibular disorder. We see this a lot in patients with incomplete vestibular compensation following an acute event. This distinction is absolutely vital because it has direct prognostic and therapeutic implications for how you're going to map out their rehab.
Which brings us to the single most critical takeaway for your clinic today. A perfectly normal standard vestibular test battery absolutely does not rule this out. Because the primary vestibular reflex pathways might be completely intact, you have to actively direct your history taking toward visual triggers. You need to ask specifically about all 9 domains of the Visual Vertigo Analogous Scale, the VVS. Ask about supermarket aisles, patterned floors, fluorescent lighting, and don't just probe for symptoms, probe for avoidance behaviors. That's how you truly validate the diagnosis.
As we wrap up this foundational overview, I want to leave you with a somewhat provocative thought about your chronic or refractory patients. Are some of these frustrating, stuck cases actually just hiding this highly treatable visual reliance syndrome? If a patient's recovery is plateaued, reevaluating them for VID might just be the exact key to unlocking their rehabilitation.
In part 2 of this explainer, we open the mechanism, sensory reweighting, the 3-sensor conflict, the cortical motion network, and the anxiety loop that locks it in.
This has been an Australian Dizziness Clinics Vestibular Physician Review. Visit australiandizzinessclinics.com for the full literature review and clinical cheat sheet. Until next time, ask yourself, what is hiding in plain sight in your clinic?